All right.
All right. So I think I know almost everybody in here, but my name is DaniGuerttman, and I work right across the hall at Wyoming Dementia Care. We are our own private 501c3, so we're separate than the Senior Center. We just rent space here, but we are our own not-for-profit 501c3. And we opened our doors to an office here at the Senior Center about 2.5 years ago, going on 3 years. So what we primarily do, and what our focus is offering support to caregivers of folks with dementia. And caregivers come in many different uniforms. You know, you can be a caregiver if you go visit friends in assisted livings or friends at home that are living with dementia, and you're a companion. You are a caregiver if you're a spouse and your loved one has dementia. You are a caregiver if your aunt or uncle or neighbor has dementia. So there's many different kind of caregivers, and what we try to do is support all of them through their journey with caregiving. So where I'd like to start is just kind of going through what we do and what our services are. And if you guys have questions at any point, please feel free to ask them, and I'd be happy to answer as much as I can. So first and foremost, what we try to do is give up-to-date information about dementia and about the disease and what it is. Common questions we get is, what is dementia? What is Alzheimer's? What is the difference between the two? Is dementia just memory problems? Which I'd like to say dementia is not just problems with their memory. Dementia is a neurological progressive disease, and it's a neurodegenerative disease. So you don't just see problems with memory, you see problems with personality. You might see problems with behaviors. You see changes, their brain is changing. And the best way I think to put it is that they are different, but there's parts of them that are the same. And the job as a caregiver is for a caregiver to adapt to where their changes are, because they don't have the ability to do that. So sometimes we get folks in that have just been diagnosed with Alzheimer's, or maybe frontotemporal dementia, or it might be a Lewy body dementia, and they come in and get education about what the disease is. What is the disease? What is the lifespan we're looking at for my loved one? What needs are they going to need as the disease progresses? Where do you think I'll need extra help? What are the symptoms? What are some of the side effects of medications? You know, all of those kind of questions is what people will come in. And what I do is I can help with disease education. What I don't do is help with medications. I don't give advice on medications or the diagnosis. That comes from physicians. And our president of our board for Wyoming Dementia Care is Dr. Wheeler. So we have a really good support from Dr. Wheeler on our board of directors. And he is wonderful at answering all the clinical questions about the diagnosing of a loved one and about the medications of a loved one. And where we can come in is more basic education about what side effects look like, what symptoms look like, behavioral interventions, support that you can bring into the home, support that's outside the home. So there's many other ways that we can plug in and help caregivers besides clinically, which we leave to a physician, and medications, which we leave to physicians and pharmacists as well. We assist families with long-term care planning. And I think when people hear long-term care planning, they think nursing home. And that is definitely a long-term care plan, but there's many different aspects of long-term care. You can get additional care in the home if that's something that you wish and your loved one wishes, in the form of respite care. And then we get the questions, what is respite care? What is home health? What are the difference? What is assisted living? What is memory care? What is skilled nursing? How does my loved one qualify for memory care? How do I pay for these, for skilled nursing? How do I pay for an assisted living? So we talk about all the different aspects of long-term care and what is going to best fit you and your loved one and your family, and where we can take into account what your needs and what your wishes are with your loved one, because every family is so different and every family has different needs. So what we try to do is assess your personal situation and what your personal needs are, and plug in support where we see that you need support as a caregiver. Any questions so far?
Is there a typical client, someone comes to you as far as age or situation or family or anything like that?
No, I would say initially we had a lot of spousal caregivers, and I think the reason that when we first opened the door we had a lot of spousal caregivers is because of our location. We're in the senior center, and a lot of folks here are dealing with a spouse that has Alzheimer's, dementia, or any kind of form of dementia. What we're seeing now is a tremendous growth in all kinds of caregivers. So we're seeing a lot of children now who are coming in who are caring for their parents. And it's what we like to call our sandwich generation. They're still caring for their children. They still have full-time careers, but now they're caring for a parent full-time. So we're seeing a lot more children come in for support. And we sometimes see aunts and uncles come in for support, and sometimes senior companions now are coming in just for the educational piece. I'm going to start volunteering, I'm going to start going into seniors' homes. Tell me what I need to know about dementia. How can I best communicate with this person? What limitations do they have? What abilities do they still have that I can embrace, that we can work on together? So no, I would say predominantly we have spousal caregivers and children who are caring for their parents. Mm-hmm. But I'm starting to see a lot of other people in the community that are just working with seniors that have dementia that are coming in for educational purposes.
Can you give us an idea of what, how common it is, or I don't know necessarily specific numbers, but I mean as far as maybe a percentage of seniors or families that are affected? Is there any information out that?
Yeah, we have about 5 million Americans who are affected with dementia right now and Alzheimer's. So in Wyoming, obviously I don't have the Wyoming statistics. Mm-hmm. I haven't posted on my desk, so you think that I would have it embedded in my brain, but that is something I could answer if I just walk across mm-hmm. the hall.
I guess I wasn't thinking necessarily about specific numbers, I'm sorry, but I mean, is it becoming more common, or becoming yes. just because we're becoming more aware of it, or?
I think that the diagnostic process has improved greatly. Before, if you think way back to even your parents' generation, where you used to hear senility and people dying of senility or just kind of losing it, now we have a really good diagnosis. And not only can we diagnose dementia as a broad term, but the neurologists have become so much better at diagnosing what kind of dementia it is. So the most common form of dementia is Alzheimer's disease. About 67% of dementia cases are Alzheimer's disease. And then we've got other forms of dementia. We've got early onset Alzheimer's, which account for about 5% of our dementia cases. And what that means is that someone is diagnosed before the age of 65 with Alzheimer's. So Alzheimer's is usually diagnosed for people that are 65 and beyond. If they're diagnosed anywhere from 30 years old, which is happening, to before 65, then we call that early onset Alzheimer's. The other most prevalent forms of dementia are going to be frontotemporal dementia and vascular dementia. So there are many, many forms of dementia, but those are the most common forms. Does that break it up a little mm-hmm. better?
So I mean, we're just becoming more aware of it.
Mm-hmm. And there's still no cure for any of these at all. There are a couple medications that can help with the side effects and can help with the symptoms, and maybe slow down the progression a bit, but is not a cure. So where we have, I think, made great advances is in the diagnosing and realizing what the disease process is that is going on. And now also the thing that has changed, which has increased our numbers and understanding of the disease, is doctors are using it as a primary diagnosis on a death certificate. So before, if somebody would have had dementia or Alzheimer's, the primary cause of death, their primary diagnosis might have been infection or might have been pneumonia. Because a lot of folks with Alzheimer's do die of pneumonia. That is one of the reasons, one of the main causes of death at the end of the disease. But now they're able to put a primary diagnosis of Alzheimer's disease and maybe a secondary of pneumonia. So that's helped. There's been a lot of advances in just understanding the disease process and how we diagnose them and how they're different. But as far as a cure, there is no cure. They're all progressive diseases, and they're all terminal diseases. So. Any other questions on that?
I'd like to inquire how Medicare pays, since this is kind of new and there are more and more of them.
That's a good
How
question.
are they relating to the cost?
How's Medicare paying? Well, Medicare will,
Like, what does it cover?
I guess, what is it covering?
okay, so it's gonna cover, initially, when you go to your primary care physician and you are concerned about your memory, it will cover all of your primary care visits, 80%, depending on what your plan is, if you have a supplemental.
Yes,
So it'll cover that. A neurologist will be covered under Medicare.
okay,
Certain therapies for people with Alzheimer's will be covered under Medicare. So if someone needs occupational therapy, or they need speech therapy or physical therapy, that can be covered, a portion of it by Medicare.
Home
If there's a doctor's order, home health can be covered. Respite care is not covered by Medicare, okay? If they get an order for home health where they're bringing somebody in temporarily to do, again, physical therapy, occupational therapy, speech therapy, then yes, 80% of that will be covered to a certain threshold with Medicare, but not respite care. Now, Medicaid, if your loved one is on Medicaid waiver, there is assistance in Medicaid waiver to help with respite care, to help with assisted living, and to help with skilled nursing facilities. Medicare does not pay for that,
yes,
okay?
yes.
All right. That's a good question.
Yeah, tricky.
Any other questions?
What all are you defining under respite care?
Respite care is going to be private pay, companionship. They can come in and help with bathing. They can come in and help with meals, meal preparation, errands. But what they don't do is they don't have a physical therapist come in and have a skillable level that they're trying to match. So if a doctor says, I think this person needs physical therapy and I'd like to get them to where they can use the restroom on their own, or to get from point A to point B with walking and get strength in their legs, then there's an order for that. And once they reach that skillable, what they can maintain, then it is removed. So home health is temporary. So it's very different than respite care. Respite care is all, unfortunately, private pay unless you have Medicaid waiver. Then there is assistance with the waiver program for many different kinds of respite care. The Senior Center has programs here that is on a sliding fee scale if you're on the waiver program. And like I said, assisted livings, not all of them. Some of them here in town have Medicaid waiver rooms, and skilled nursing homes, all of them except Medicaid waiver.
Can you help a care provider get those waivers? Do you know the procedures and help work them through
The process?
Yes.
Mm-hmm. Yes, and if I can't personally do the Medicaid waiver paperwork, then I can hook them up with, I work with quite a few social workers through different agencies here that I will, that we collaborate with, that will help them through the paperwork, because it is a lot of paperwork. It is not easy to navigate through, and so we work with places like Interim Health Care that help with Medicaid waiver. We work with some private agencies that help with Medicaid waiver, and then I can also help. And the nursing homes also have caseworkers that can help with that. All 3 nursing homes have social workers that should be able to help with getting people eligible for Medicaid waiver.
And that's what I was going to ask you, the different agencies that you network with and work with, because people don't get respite care from Wyoming Dementia Care. I mean, it's so, like, and you mentioned Interim Health, others that you work with, that
Yes.
State and federal agencies and that kind of thing too?
Yes, so to kind of start locally, we work very closely with Interim Healthcare. We work closely with Caring Hands of Wyoming. In fact, Caring Hands of Wyoming are the folks that provide all of our respite care, all of our support groups, because all of our support groups has free respite care for caregivers. So that we would do in collaboration with Caring Hands of Wyoming. We work very closely with all of the assisted livings here. We work with them in regards of transitioning families. So if I have a family that is transitioning into an assisted living, I can help with that and deciding, whether memory care or assisted living is going to be better. I also help work with the assisted livings in regards of training with the CNAs and nurses on dementia care and dementia education. And so we work with all of them. There's 5 assisted livings here, 2 of which have memory cares. And then there's 3 nursing homes that we work very closely with. And again, Wyoming Dementia Care's role is to support the family during transitional times of transitioning a loved one into a care facility. So we partner with all of these facilities to make that transition easier for families that need to go through that. As far as federally, we have a grant through the Division of Aging, and we're one of the only entities in the state of Wyoming that have received a Title III grant through the Division of Aging. Most of those grants, the recipients are the senior centers. And what they do is help us with some of our programs that we offer direct services with. So some of the other services that we provide that are direct services are case management. So kind of what I'm talking about when we're talking about walking families through transitioning loved ones, doing education with families, assessing what families' needs are and being able to plug in support where needed. That's case management. We offer an art class in partnership with the Nicolason Art Museum, and this program's been going on for about 1.5 years. And it is a dementia-focused art class for caregivers and their loved ones to be able to communicate through different venues other than just basic communication, and they can communicate via art. And so the federal grant pays for services like that are direct services. And for services for folks that are 60 or over. So we do track our demographics, and folks that we're helping directly that are 60 and over, our federal grant helps pay for that. So.
And that's your primary funding is federal money?
That's a big portion of it, and there's a good chance we might not be getting that in the future just because of structural changes in the way the federal government is handing down these grants. So the way that Wyoming Dementia Care is funded is solely through grants and then donations, private donation and through grants.
Affordable Care Act is not involved at all in dementia?
Affordable Care Act is involved as far as, well, the NAPA Act was one of the first acts that was passed when Obama took over, and that's the National Alzheimer's Action Plan Act. So there was a lot more money that was put into research for Alzheimer's. And the other place where the Affordable Care Act has really made great strides in supporting caregivers is they're mentioned. Caregivers, the exact word caregivers, is mentioned about 27 times in this huge, I mean, if I could unroll the Affordable Care Act, we could do it about 15 times through this room. So in one way, it doesn't seem like it's enough. But the fact that caregivers were mentioned 27 times in this Health Care Act is a victory. And the way that they were mentioned was ways to better support caregivers who are caring for their loved ones at home, because they are the main backbone of our long-term care, and they're unpaid, and they're unrecognized up till now. So now the government and the federal government has recognized that we have to support our family caregivers, because they are providing the care for most of our disabled and elderly in the country.
Recently, there was a notice somewhere about caregivers often expiring before their person they were caring for, because they overburden themselves.
Right. It's,
Is that still true? And okay.
Yeah, and what we're seeing, and I have to try to remember the exact verbiage because it just came out today, actually, a study that people that are over 60 and caring for someone with dementia, so not just broad-term caregiving, but someone that's caring for dementia, does have about a 50 to 60% chance of dying earlier than the non-caregiver of the same age bracket. So it is a big jump. And caring for someone with dementia, what makes it so unique is the trajectory of the disease, for one, is anywhere between 4 to 20 years is what they used to say, and now they're narrowing it a little bit to 6 to 12 years. So that's a long journey to care for somebody. And this person that you're caring for is constantly changing. So the needs are constantly changing. And they aren't able to adapt, and they aren't able to work through these changes. So it's solely up to the caregiver to make all the adaptations to their lifestyle to better care for these people. And it's the hardest part, I think, is that they're losing the person that they've always known. and they're caring for someone that's new and different. And that's a really difficult chore. And they generally, as the disease progresses, need 24-hour care. They're going to need help with bathing, they're going to need help with toileting, they're going to need help with eating, they're going to need help with everything they do. And it's a long process, and like I said, it's constantly evolving for the caregiver. And that person they're caring for is constantly changing. So it takes an incredible toll on a caregiver to work through that.
So how do caregivers, families, how do they find Wyoming Dementia Care? I mean, will they be referred from their physician, or how does that usually happen?
So generally, a lot of our referrals come from our location. Location. When you walk in the door, and here we are at the Senior Center, which is a good place to be. We do have a fax referral system that we use with physicians now. And what that does is allow a physician, upon diagnosis, to fax their information directly to me with their permission. So I can intervene right away with education and offer supportive services from the get-go. And that's a big deal, because statistically, caregivers usually wait about 2.5 years to ask for support. And that doesn't mean 2.5 years after the diagnosis. That's usually 2 to 2.5 years after they're struggling and wondering what is out there for help. So that eliminates that if we can get more physicians upon diagnosis to refer directly to us for supportive services and education. And this fax referral system is also in Wyoming Medical Center, Cerner, which is their computer system. So now all the docs at Wyoming Medical Center have access to it, as well as the social workers and caseworkers. And I've met personally with most all the caseworkers on the neuro floor, which is where we see most of our dementia cases, and they're aware of our services. So when they're discharging a patient out of Wyoming Medical Center, they're not left flailing. They can generally call me and say, we're discharging this family, they need education, they need support, and I can step in because all of these hospitals are acute settings, and they deal with the acute immediate need, and then discharge the families. And so it's important that these families have follow-up when they're discharged from the hospital and understand what their options are and what resources are available. So the fax referral system we get a lot of referrals through physicians that way. A lot of the primary care docs are referring directly from their office. Obviously, we have a neurologist who refers a lot of the folks that he's diagnosing to Wyoming Dementia Care. Other than that, we will have a website up very, very soon, I hope. And so I think that will engage a lot more of our children who are caring for their parents, who are still at work, and maybe their only means of trying to gain education and access to resources is through the web or through Facebook and social media. So once our website is up and going, then we'll be able to be in touch with all the different social media aspects too, as far as Facebook and Instagram and Twitter and other means of communication.
What kind of help, does Wyoming Dementia Care need? Do you need cash? Do you need volunteers? Do you need both? Do you need something else? Or?
Okay, so let me just tell you a couple more things about what we do, and I think that will tell you more about what our needs are. So we do offer support groups, and when we first opened the door, we just had one support group that met here in the mornings. We have 5 support groups now. We have 2 that meet here the first and third Thursday of every month. We have 2 evening support groups that meet at Meadow Wind now at 6:30, the second and fourth Wednesday of every month. And now we have a midday one on the west side at Mountain Plaza Assisted Living. So
That meets when?
the second Tuesday of every month. To keep on track of all. All of these have free respite care, so so people can bring their loved ones to all the support group. So that's one of our services. We also offer free counseling, and when I say free, we work in collaboration with Central Wyoming Counseling Center. So for folks that may not do as well in a group setting or just might need that extra support and extra counseling, we offer that to caregivers, private one-on-one counseling. And that can be done either at the counseling center, it can be done here at my office, it can be done in people's homes, and Wyoming Dementia Care pays 100% of that for caregivers. All of our services for caregivers are free. So one of the best ways to support Wyoming Dementia Care is obviously through donations, because we don't ask caregivers to pay for any of their services whatsoever. And that includes counseling, that includes art, that includes support group with respite care, that includes case management. Am I missing anything? Community education, outreach. We offer free memory screenings throughout the year. We usually do at least.
I got that.
Did you?
From
And
you.
You
Yep.
did well, right?
Well, don't.
Yeah, so we do memory screenings at
Should let
least
me
twice
out.
a year. And a lot of outreach. We do some brain training classes on brain health, ways to promote a better, healthier lifestyle. Not necessarily means that, it doesn't necessarily mean that you won't get Alzheimer's, but what are the best ways to build up odds that you will have a healthy life and a healthy lifestyle.
Is it inherited?
So that's a tricky question, and I do like the neurologist to answer that. But basically what they have found is there is a greater link with early onset Alzheimer's than there is with regular Alzheimer's. There is a way to do genetic testing now to see if you carry some of these genetic traits. And so it is an option that if mom or dad or grandma had Alzheimer's, that you can do genetic testing. I think what they're saying is it can increase your odds, but to what extent they don't know, but you can do genetic testing now to see.
What difference it make? They can't do nothing about it anyway.
Right now they can't, there's no cure. No, there's no cure. But early intervention is important. You know, so recognizing symptoms early on is important. And getting diagnosed early on is important. Because there's a lot of things that can be done to help. You know, there's medications that if they're brought on earlier in the disease process can help with symptoms. And there's also a lot of intervention that can be done as means of behavioral interventions, resources, support for families, education for families. So I think the earlier that someone is diagnosed, definitely the better. Did that answer your question?
I think so, yeah.
Okay, so we have a lot of services. And
How
like I
many
said, they're
people in
free.
your office? How many people work there? You and?
Me. And then we have Carol Crump, who does all of our grants, which is incredibly important because that's how we fund Wyoming Dementia Care. And a lot of the kind of the behind the scenes work is what Carol does as far as grants and billing and
The two of you then.
yep. And she works from home. So I'm the only one in the office, and I do all of the support groups, and they are all co-facilitated by Kelly Shipley, who's at Central Wyoming Counseling Center. She is a licensed clinical social worker, and she's been co-facilitating these groups for probably about a decade. So is not only very well credentialed, but she also is so in tune and understands the demands and all of the processes that go on with caregiving. And that's actually who does most of our private counseling as well. So I'm at all the art classes, Kelly co-facilitates all the support groups, and then I do all of the case management and all of the outreach and memory screenings.
And your caseload now includes 50 people, 75 people, 2 people, 3 people?
At least serving about 70 people at least a month. So, yeah,
It's a lot.
I have in my little brain a lot of wedding anniversaries, what kind of dogs they have, where they
Yeah.
lived.
Yeah.
And it's funny the little tidbits that I can remember, but sometimes it is, you know, an anniversary or what kind of dog they had or where they grew up. Or yeah, I work with a lot of families, and what I love about my position more than anything is I don't work with them once. I generally work with them throughout the entire process. It's my hopes of the disease. So I might initially just see them and give them some information about what the disease looks like. But I follow up with these families through the process. I see them in support groups. I might see them in art. As their needs become greater, I'm able to plug in whatever support they may need. And that's not always respite care. Every person is very unique in what their needs are. And that's a really important part of getting to know our caregivers and what support they need, because not everybody is looking for a nursing home. Not everybody's looking for respite care. Some people need help in the form of, I need someone to come in and help do my wife's hair. I need someone to help pick up medications and do meals. Everybody's needs are very unique. So there's not one fix-all for everybody. We really try to engage the family and really try to assess what their needs are and what's going to best help them. Because there isn't a blanket solution for for everybody.
Do you serve the whole state or just Natrona County?
Right now,
or-
just Natrona County,
Yeah.
we've done a little bit in Converse County, because the staff is me.
Mhm. And so the other parts of Wyoming, are they just underserved or?
Yeah, absolutely. You know, I think we have had a lot of calls about wanting to duplicate our program. How did you make this program happen? What connections did you need? What collaborations in order to make, because it's very multifaceted, our program, and it's very holistic. We look at caregiving from a very holistic point of view. We look at people's mental health, we look at what their social needs are, what their physical needs are, and we try to address every aspect of caregiving and plug in where their needs are. So to duplicate this program in Wyoming would be incredible, to take it into other counties that could have the same kind of resources. And if we can just start, as Wyoming Dementia Care did, with just support groups, that would be a tremendous help. And there are more support groups growing throughout the state. So we have been asked to work with the state in possibly developing an Alzheimer's state plan and duplicating kind of our program and how we did it and seeing if we could do it in other counties. But we personally would not be providing those services. It would be kind of presenting a model of how we did it here and implementing it in other areas. So,
Do you have any statistics from the onset of memory loss to begin with that eventually becomes dementia or Alzheimer's until they die? Is there any statistics about the lifespan in there?
so if we're looking at Alzheimer's disease, so this is just one form of dementia.
Yes.
They used to say 4 to 20 years, which is very broad. I've heard it now, they're narrowing it a little bit more to 6 to 12 years, and I think a big part of that is, again, the early intervention, the early diagnosing of folks. But 6 to 20 years generally with Alzheimer's disease from noticeable onset symptoms. That doesn't mean that there weren't symptoms going on 3, 4, 5 years before that, but when it becomes very noticeable and apparent to where you go seek intervention from a physician
Okay.
to end of life. But that's Alzheimer's, and that's unique to Alzheimer's disease. You
Yes.
see a much quicker progression, downward progression in something like a Lewy body dementia. Frontotemporal generally has a faster decline, and early onset generally has a faster decline than Alzheimer's disease. And does anybody know the biggest risk factor to Alzheimer's disease?
Risk factors.
The biggest number one risk factor of being diagnosed with Alzheimer's disease?
Suicide,
Age.
age.
Okay, so as you get older, your risk factor increases.
What is Lewy body? Is that, what does that term come, it sounds like a bug or something. What is
It's
it?
actually some of the, and again, I'm not a physician, so I'll put my disclaimer out, but part of what they're finding, the clinical findings on a diseased brain with Lewy body, that's what they are. Like in Alzheimer's, you call them plaques and tangles.
Yeah.
And you find plaques and tangles on an Alzheimer's disease brain. But what you find in a Lewy body disease are these Lewy bodies. And that's where the name comes from.
What is a Lewy body? I know some Louis,
Yeah?
but I know some bodies, but I'm sorry, I don't get the connection somehow. You
Well,
say it looks
making
like
trouble.
It's a
Lewy
clinical
body.
term. I mean, it's a clinical
Is
term.
it a
Just
Fair
growth?
enough, okay,
Okay.
I'm
Is
sorry.
it a growth like a tumor?
Hmm?
Is it a growth like a tumor?
No. No.
It's indescribable.
It's describable by neurologists. It's qualified to describe exactly what Lewy body looks like on a brain.
Mhm.
Yeah.
I would think the change in personality must be the worst for a caregiver.
The ongoing, forever changing personalities,
Yeah.
yes, and ongoing, forever changing needs, for sure, are incredibly hard for caregivers.
Yes.
And, you know, caregivers go through a grieving process for years during the disease,
Yes.
because they're constantly grieving something new with their loved one. You know, initially it might just be that they're grieving that partnership of being able to make decisions together and planning together, working on finances together. All of a sudden it's solely one person's responsibility. But that grieving process continues and greatens as you lose the ability to communicate with your spouse. You lose ability to have intimacy with your spouse. All of these things come with such grieving processes. So it's an ongoing challenge, it's an ongoing need for support, emotional support, mental health support. And the physical demands are incredible on a caregiver. When you're talking about needing to keep an eye on them 24 hours a day to make sure they're safe, when you talk about needing to toilet them, to change them, to feed them, to dress them, to get them ready to go to doctor's appointments. So there's a great physical, mental, and emotional toll on caregivers, and that's why we are here, is to plug in wherever we can to best support them through those challenges and through those processes.
Well, a couple who've been married for 50, 60 years, and suddenly the wife is taking care of him, and he was a loving person for 50, 60 years, and she has all of those memories. With a personality change, it suddenly just reverses to where he is almost mistreating her. And that must be terrible for a person to try and handle. When she's called names and isn't recognized, and it's like a stranger.
Exactly, and that's why the educational component is so important, so we can differentiate what is actually happening in the brain, what is happening in this diseased brain, and what is personal. And that's what we need to do. We need to understand what is happening in this disease process. We need to understand what's happening in the brain and what's being affected, whether it be shrinkage, whether it be plaques and tangles, but what parts of the brain are being affected, and that's why this is happening, not because your loved one likes to ask the same question 50 times in an hour. They're not doing that to drive you crazy. It's part of the disease process, and that's why the educational piece is so important, because you can empathize and you can relate better once you understand that this is the disease and this is the diseased brain. This is not my wife. This is not.
How many times do you have to hear this before you tell her to shut up?
Yeah.
Yeah. That's where breathing comes in. Breathing techniques when you're.
I think it's easy for you to say, and we comprehend that it's just a problem of the brain, but when I go to the nursing home, say, a nurse, the grandson comes out of the room from his grandmother who's into Alzheimer's, you know. He's been doing it for maybe 2 or 3 years, and he keeps on saying. So when I went in there, Grandma goes, well, how come you haven't seen me for so long?
Right.
And I just went out to get a drink of water. I was in there 5 minutes ago. He was ready to start crying. But now this is a pattern that's going on, but it seems like sometimes people, it still hurts them.
It does.
I mean, can you ever get over that, or can you deal with it? How do you deal with it? You know,
These are big questions.
Well, they are.
You know, here, I think, again, the educational component's important. And I'm not saying that that eliminates the pain and that eliminates the hurt of your loved one not
Right.
recognizing you. But I think that you get better coping skills once you understand what's happening, and once there's some kind of intervention to say, you know, maybe that this is a better way to communicate with Grandma. This is a better way to answer your questions. To where maybe you can redirect Grandma in the way that she is.
well, for example, you know.
Okay. I'll give you an example.
Yeah.
Okay, so maybe the grandson was just visiting Grandma, went to go get something to drink, comes back, and where have you been? I haven't seen you for a long time. Rather than arguing and saying, Grandma, I was just here. I don't know what I was just here with you. Her brain doesn't know that. Her short-term memory's gone. So maybe a better way is just sitting down and first we have to know Alzheimer's patients and dementia patients have a very narrow, their vision field is even different.
Yes.
Their vision field has been completely impaired by the disease. So before, where we can see in front of us and peripherally, they don't. So what's important then is maybe for the grandson to come to Grandma and sit at her level and look in the eyes and just say, well, I'm here with you now, or I'm sorry I wasn't here. But don't argue with her. That's a form of intervention, is not, I was just here, Grandma. But, well, I missed you, Grandma, and here I am, and maybe talk about a memory that she does. You know, there are a lot of things that they still do have, and that they still embrace, and a lot of that is music and long-term memory. So maybe you just sit down and say, well, I'm with you now. You know, let's sing your favorite song, you know, but not arguing with somebody.
Well, that's a different approach, I think, than what, I can't tell a relative what to do, because they love their grandmother more than I do, but
Can be pretty easy to
You're not-
redirect them though, too.
Redirection's important.
You, in other words, you are not trying to have a rational discussion with them to help them understand, I was just here 5 minutes ago, Grandma.
No, that
Because
processing
they are
is
not
gone.
Yeah.
capable.
They're-
They're cognitive processes. So, you know, there's two things, there's the brain, there's the heart. The heart goes, Grandma, but I was just here, you're killing me. You know, all this time I spent you, but the brain has to be able to register that Grandma doesn't register. So I think,
And our
In a
brains are
sense,
able
this-
to do that. We're able to adapt.
well,
They're
well,
not.
to a point, because see, this grandson for 2 years has been going through this cycle where he's like, shit, you know, it's like, I might, oh, edit it out. You're like, I might as well not even come here anymore, because my grandma, you know, doesn't even know I'm here half the time, or sometimes say, who are you? And I think he's on his level, he's trying to envision a world in where she will communicate rationally, cognitively,
Yeah.
in a way that, like grandma used to be. But if you come to a point where you say, I have to give up that illusion, she's not that way anymore, that is painful
It
to
is
do.
painful, and that's one of the
but-
processes we're talking about, of getting help and support and counseling through is, that is the new grandma, that is the new situation.
To-
It's not gonna change.
All right.
So how do we best cope and adapt, and what skills can we use to adapt to this new grandma?
We have to allow that, I have to allow that grandson then, in a sense, to be able to be sorry that, in other words, I can't tell him, hey, quit feeling that way. No, he has a
No.
right to feel sad.
He
that
needs
his
to
grandma
grieve
doesn't
that.
recognize him. But he also needs to develop some kind of skills where he can relate to his new grandmother.
Right,
Oh,
and
all
there's
right.
still plenty of moments to be had with grandson and grandma. You have to find where she can still connect and embrace that. And they still can connect to the very end in different ways. There are certain parts of the brains that are always preserved and different ways to always connect, even to end of life. It will not be in the ways that they used to in the past. It may be through music, it may be through touch, it may be through another kind of sense, but there are ways to connect.
Well, I think
With
with the
folks.
grandson, by going, he will feel calm after grandma is gone, that he did go. If he didn't go, he'll feel guilty that he didn't go.
My daughter made an observation that, because my wife is in an Alzheimer's unit right now, my daughter made an observation I thought was really good, and she said that, that mom's not gonna remember. She's not gonna remember this afternoon if we were there this morning.
Yes.
And so when we go see her, we're primarily going for us and not for her,
That's right.
because she's not going to remember.
Right.
And
he'll-
so, and so that was one thing. And the second thing is that I think the earlier in the progression that you get help, the easier it is to become acclimated and to be able to roll with all the changes that the disease brings. So I think that those two things, first of all, getting help really early is important. But the second thing too is that going to see her, like this young man you were talking about, is really not for her, but it's,
Yes.
you know, it's for us.
He'll feel
And-
better after she's gone.
Yeah.
He won't feel so guilty.
But there are ways, I just want to reiterate, there are ways to still connect
Yes.
Yes.
with your loved one. It
Yes.
is not going to be in the ways you used to before. And they're still a person, and there's still
Yes.
there's still parts of them that are themselves.
Thank you.
It's up to us to find what that is. It's up to us to talk to clinicians and ask cognitively where they're at. It's up to us to find where we can still connect with our loved ones or our neighbors or our families. They are not a shell of a person. They are still a person, and they still have needs. They have needs to feel that they have a purpose. They have needs to feel loved. They have needs to be touched. And there are ways to connect. We just need to know what part of that brain is still working well, so we can connect in that way. And one of the best ways to do that is through music, because that is one of the parts of the brains that is the latest affected by the disease process. Touch is incredibly important. I mean, these needs for humans don't go away. And like I said, your moments that used to be able to spend 2 hours with grandma and connect and reminisce and have great stories. Maybe your time now with grandma is 10 minutes, but that 10 minutes is important. And so I don't ever think that you kind of give up and believe that they don't they're a shell of a person, and there's none of them left. Because they still have a soul, they still have a heart, they still have human needs for touch and communication and purpose, and even at end of life, those needs are still there. It's up to us who are able to adapt, who are able to educate ourselves, who are able to work with physicians and clinicians. How do I best connect with this loved one? How do I best connect with grandma now? What does she do? She still has abilities. That's what we need to embrace. We need to kind of forget about all the things that grandma can't do anymore. Well, she can't carry on a conversation with me. She can only put 2 words together. Let's not think about everything grandma can't do anymore. What can she still do? And if it's only 10 minutes worth of something, then you embrace that and you enjoy that moment. And you continue to adapt.
My husband, I said the greatest thing was that he didn't wander,
Mm-hmm.
and his part of his was he liked to go out and sit in the swing, watch the cars go by.
Yeah.
And we would sit there in the afternoon for hours. And he'd count maybe the car that didn't have his headlights on, and he should have. But that was what he enjoyed.
He enjoyed it.
And we did a lot of that. But I didn't know that there was all these programs when my husband was sick.
Well, we've only been around for, as far as having an office location and all of these supportive services for 2.5 years. Prior to
See,
that,
and he died, it'll be 5 years in January. And I put him in Poplar the last 2.5 months. The rest of the time I was at home with him, but like you say, it was,
Well, what a
But the-
lot of it is though too, is the caregiver doesn't want to give in. They
Yeah.
don't want to accept the fact that it's there.
yeah.
And they're not going to get the help until it's too late.
yeah, acceptance is a big part of this.
Uh-huh.
And getting a whole family to accept that a loved one is diseased, it has this disease, is even more difficult. And so you see a lot of
Yeah.
fractured family relationships over this disease process. 'Cause
And now I look back and I think we had my grandmother in my home, in our home when I was 14, 13. And I look back now and see a lot of the things that,
Right.
that,
This is a little different from what I hear from people I meet though. I mean, who care. When it comes up, they generally say, grandma's gone. That's not my grandma anymore.
It's
Well, my
not the
grandma-
grandma they always knew.
Yeah,
Right.
but no, I think they actually come to a point to where, I mean, literally, I don't know how much they mean it graphically, but they say, that's not my grandmother in that room anymore.
Right.
She's gone.
We're gonna wrap up here.
And I don't think they see it the way you see it, that there are ways of it, she still
There are ways to.
is a real living, vital human being, but
Well, I think
That's
we,
part- yeah.
yeah, I was just saying, we've covered a lot of topics today, so you're certainly available in your office to, to try and answer anything more in detail, or...
I'm happy to always.
Yeah, and you've got
visit.
some business cards there too, so...
Yeah, so here's some brochures if anybody needs them or knows somebody that could use some information or resources or support. Here's my business card, and I always have cards and brochures in my office. I have lots of books for caregivers.
One of each.